Welcome everyone, and thank you for joining us for today's presentation, Repealing the ACA, Effects on Counties. We have with us at the end of the line here, Farah McDade Ting, one of my colleagues here at the California State Association of Counties. She's our legislative representative that works on health and human service issues, and of course that includes the Affordable Care Act. Next to her is Michelle Gibbons. She's the Executive Director of the County Health Executives Association of California, known as CSAC. A former colleague here at CSAC. Michelle, it's really nice to have you back with us today. And then on the phone we have Tom Joseph. Tom Joseph is the Vice President and Managing Partner at Waterman and Associates, CSAC's federal lobbying firm. They're the firm we contract with to do our lobbying there, and I know they represent a number of other counties in the state as well. And so, Tom, we're going to kick it off with you. If you could let our folks know, the folks on the line, about what's going on in D.C. It seems like things are moving really fast there. The last I heard, the Republicans had the goal of finalizing their bill by January 27th, but that's Friday. And from what I hear now, they're not even in D.C. right now. So what's going on?
Well, that's correct. They are not in town at this point, and I think the key takeaway from my presentation is that everything indeed is extremely fluid at this point. Let me start off by talking about the Senate. I think there's a chart that we have that shows the makeup of the Senate at this point, and the key takeaway in that chart is that there are 52 Republicans. And with the legislative process that the Senate is expecting to use, called reconciliation, they only need a majority vote to repeal the Affordable Care Act. That reconciliation process is protected from filibuster, and there is a limit on the number of hours of debate. So with 52 Republicans, it only takes just a couple to express concerns about repeal that will effectively stop or delay any sort of repeal bill. And that's, I think, one of the reasons why we're not seeing a finalization of a repeal bill by this Friday.
Tom, can I ask you, does it look like, is that a real danger in the Senate to the Republicans' plans? Are there two or three or more Republicans who it looks like might not vote for the bill at all?
There are right now, and it's depending on how strong they've come out in terms of not necessarily repealing it. The Republicans' concerns have been, if indeed we're going to repeal the Affordable Care Act, we need to simultaneously have a replacement bill. So there are roughly 7 senators that have expressed on the Republican side that kind of concern, that repealing without a replacement is not something at this point that they want to see. So yes, the January 27th date was not set in stone in terms of force of law. That was the date in the budget that at this point is aspirational. The timeline, the actual timeline for drafting a repeal bill remains unclear. The bill is likely to be ready by mid to late February. In the meantime, as many of you may have read, President Trump on Inauguration Day did issue a sweeping executive order to federal agencies to direct them to ease the burden of the ACA, but the actual effect of that order is very unclear at this point.
Have there been any concrete actions that we know of from federal agencies to comply with that order?
Not at this point. There's still a question of exactly what easing the burdens of the ACA means. So there's not been any direct action by the agencies, primarily because the secretaries of those agencies, including HHS, have not been confirmed by the Senate yet. So this Beginning today, House and Senate Republicans are meeting in Philadelphia. They're meeting for 3 days to discuss a few key issues, tax reform being one. The second issue is what is indeed their ACA strategy in terms of moving forward with the repeal and replace bill. And President Trump is expected to speak to them on Thursday. So we may learn more this weekend, but it's still not exactly clear how much we'll learn by the weekend. Next week, the House and Senate are going to have hearings as opposed to a markup of actual legislation. The House and Senate committees will conduct some hearings on what they view as problems with the Affordable Care Act right now and what may be a better replacement. So that's another thing that here in D.C. and hopefully you in California will pay attention to. It may give us some indication of the Republicans' plans for repeal and replace. And then yesterday, Secretary-designate Tom Price, a orthopedic surgeon from Georgia, former chair of the House Budget Committee, went before the Senate Finance Committee, which has the jurisdiction of confirming HHS nominees. He was asked over the 3 or 4 hours of that hearing a number of questions on his position on ACA repeal and replacement. He has indeed, as a member of Congress, introduced bills to do just that. But yesterday he was very, very vague on exactly what his plan is that he would propose to President Trump. And President Trump has said that he'll have a better plan, or he'll have a plan submitted once Price is indeed confirmed.
Have there been any indications from the Trump administration about what any of the specifics of that plan might be? Do you think it'll mostly conform to the House plan, or are there some marked differences?
My sense is there was indeed a bill that was adopted by the House and Senate last year that was vetoed by then President Obama. My sense is that that's the bill, the repeal bill, that they would use as a foundation to work from. Really, the key issue is what will replace that repeal, and that question is very much an outstanding issue.
That's a big deal for us here in California, and one of the I know in our joint letter that a lot of county organizations signed on to, that we sent to Congress, one of the main points is there needs to be an immediate replacement. So, earlier this month, people were talking about repeal and replace within 2 years. Has there been any movement on that? Is this what some of the Senate Republicans are holding out for?
The actual phasing out of the Affordable Care Act still is an issue. Whether it's 2 or 3 years remains an outstanding question.
But is there any chance that a replacement will be? I mean, will they have a replacement language ready by mid-February?
I don't know.
Okay.
To be totally honest with you.
Sure.
Yeah, I mean, there's a lot of, this is fair McDade-Ting, there's a lot of unanswered questions at the federal level. What I like, the catchy phrase is, are they going to repeal and run or repeal and replace? And I think Tom, as Tom mentioned, we don't know really on either. But there has been some traction, I think, on the repeal and replace side of things.
Exactly. I think there's more and more Republicans that are realizing, especially in those states, and there are indeed a number of Republican governors who did take advantage of the Affordable Care Act expansion under Medicaid, and they have contacted their senators and said, we need an idea, we need a firm idea of what the replacement bill looks like before you pull the rug out from under us on our Medicaid expansion.
And then I saw news this morning that there were 2 senators from, I believe, Louisiana and Maine who were proposing what almost sounded like an only less of a repeal, where maybe some states where things where they like the way it's gone, they'd be able to retain their exchanges and retain some of the consumer protections. Is that a bargaining chip, or is that something that might actually happen? What's your sense of that sort of change to the plan?
I think it's an initial bargaining chip. At least somebody on the repeal side is beginning the conversation of what a replacement bill may look like.
And I think even on that one, when you start to really delve into it, it does talk about states that like it being able to retain kind of affordable care-like traits. What it doesn't talk about, I mean, what it also references is a cut to the federal funding that would happen under that construct. It would be 95% of the funding that would have ordinarily been available, but it doesn't talk about whether that's capping it at a point in time or capping it at a per person, whether it would grow for states based on enrollment and so forth. So I think even looking at that initial plan that was laid out, what the impact would be to states is still, you know, really unknown. Mm-hmm. And if it's capped at certain amounts, it could be detrimental to our state. Even the 5% is detrimental to our state in terms of how much that would be in federal funding.
The 5%.
So it's of the federal funding that you would have received, you now lost 5%. But again, it doesn't talk about whether that's capping it at a point in time based on enrollment or anything like that. Would you agree, Tom?
That's right. That's exactly right.
What I would add is that this process that Tom is talking about is really, it's the budget process of the federal government. And so any repeal under this process would repeal the fiscal underpinnings of the Affordable Care Act, not necessarily the main policy provisions that many people are very familiar with, like the individual mandate and on your parents' plan until age 26 and pre-existing conditions. Those are policy parts of the Affordable Care Act that would still stand. However, by repealing the fiscal underpinnings of the whole thing, it will undercut all those policy provisions. The main concern for counties is, of course, undercutting the amount of funding we get for serving Medi-Cal enrollees. Losing the federal matching rate that is available under the Affordable Care Act would be devastating. But the repeal, what they're talking about is the fiscal underpinnings of the act.
Well, can I ask about the 5% loss? Because wasn't the plan always that the federal government share of the costs would, after the first few years, start declining? Mm-hmm. So is the 5% loss, is it in line with kind of what we were expecting anyway?
I don't think so, because the way, and again, it doesn't really specify how it would work out, but the way that I read the initial kind of part of the plan was that it would be like, in addition to the dwindling of the enhanced matches that's provided to California, it would be an additional 5% loss on top of that. Now this is kind of high-level speculation. There's no detail in terms of how that would actually play out.
Yeah.
Sure. Well, and the federal share cost dwarfs the state share, and so a 5% cut would be $16 billion in the current year. 5% of that is a lot of money, mm-hmm. right? It's, I don't know, almost $1 billion. So what are the state's options? I mean, under that proposal, or under, maybe a more drastic proposal where all of the funding is cut out, or a fair amount, is that even something that's conceivable? Is that all of the federal money for the Medi-Cal, Medicaid expansion would go away? I don't know if that's a question for Tom or for you guys.
Mm-hmm. I would hope it's not conceivable. I don't know what the state's options would be. I think what we have heard from our members, in the legislature, is that they are committed to making sure that Californians retain coverage. How that plays out, what the state is able to negotiate and work out, it's still unknown, and it's still really early to speculate kind of what that would look like. I think that there is interest in making sure that there's some type of coverage, but again, it depends on what the actions at the federal level would be.
And I would also say it depends on the commitment or the amount of money that the state has to throw at this problem. If they lose, $16 billion in funding, it's not something the state can absorb easily. Governor Brown, in his State of the State yesterday, talked about fiscal prudence, talked about his estimates of the revenues for the state going down. So any loss, even the 5% overall cut, conceivably could be backfilled by the state. That's what people would suggest, but whether the state can actually do that or not is really up in the air.
And of course, they would be competing against childcare and competing against school funding and competing against all of the other goods that government does, as Governor Brown has said before. So, Tom, can I ask you, is it conceivable that all of the money for the that right now is paying for the Medi-Cal expansion would go away, or are we just looking at some portion of it that would be gone over the next year or two?
There are probably a number of ways of answering that. Let me look at it a couple of ways. If there's a replacement bill, I believe that California and many other states, they would not just totally take away all of the funding that states enjoyed under Medicaid expansion, but how they pay for whatever's left remains very much an outstanding question. A second scenario would be, there's a lot of talk about block granting Medicaid, capping the amount of money given to states. Some states would argue, and I would imagine California would, don't penalize states that took advantage of and have now in their baseline Medicaid expansion monies. That should be in the baseline of any sort of new Medicaid block grant. I could see other states, though, who will say, gosh, we didn't take advantage of the Affordable Care Act because it was not something we wanted to do, but don't penalize us by not giving us any sort of new bump because we didn't expand Medicaid. So we could see a big battle between governors and states in terms of how do you include Medicaid monies that have been used by the states to expand care in a replacement bill.
Let me go back to Michelle and Farah. Before the Affordable Care Act passed, the state and counties in some combination were providing health care to people. If it goes away, why can't we just go back to doing it the way we did then?
There are a few changes that have happened since the Affordable Care Act came into play. I think one, we are seeing huge numbers of people who have gained insurance coverage through the Affordable Care Act, more than what we were covering initially. And so conceivably, should, let's say, the Affordable Care Act was repealed, we would see not just the population at the county level that we served before through our Section 17,000 mandate and through our indigent care programs, we'd likely see an increase in individuals seeking care just because they are now familiar with getting care. So part of what the state did when the Affordable Care Act came into play was they implemented what we like to call AB 85, which was really the state diverted what they thought would be savings from us no longer having to serve a certain population now that they got coverage. And so
people who were previously medically indigent,
yes,
and would show up at emergency
Served by
rooms
the
or
county.
yes, served by the counties. And so should a repeal of the ACA happen, there is a part of our funding source that has gone away that we would then need to revisit through 1991 realignment negotiations.
So that part of it, so that money was money that was going to counties before. It's now in the state's budget. Presumably the state's been using it. They haven't just been hoarding it somewhere. So are there, would those services be the ones that would be at risk at the state level? Farah, is that something you can...
Well, what the state diverted the health realignment money for was to help fund CalWORK's grants increases. And those grants have increased over the last few years. If the funding went away through AB 85 because the counties needed that money again, the state would have a general fund cost that they would have to backfill for those CalWORK's grant increases. And that could make them look at the CalWORK's program and look for efficiencies there.
And by efficiencies, you mean reducing,
as much
cutting
as you
grant
can.
amounts.
We're talking about federal programs, that federal safety net programs, and I don't think anybody in California wants to see cuts to either health or CalWORKs.
But again, that's kind of looking at if we kind of return to the pre-ACA structure. I think it's really hard to really fully understand what would happen, because again, there's a potential for the state to want to do something to help backfill any cuts and create programs. There's just a lot of uncertainty about what direction our state would go, and then what responsibility would then shift back to the counties.
And the other thing that Michelle's folks especially, we used to run indigent healthcare systems, and we've gotten mostly out of that business, and our money for that has been diverted by the state. And if the ACA were to go away, what would our health departments have to do?
Yeah, there would be a lot that would need to be done to rebuild that capacity. Whether I think we saw enrollment drop in our indigent programs by drastic numbers in some areas especially. And so rebuilding the capacity, the clinic systems and so forth, to be able to then revitalize that indigent care for such a grand population would take significant resources beyond what we currently have, beyond possibly what we had before.
So this is something that I hadn't really thought about before. When the Affordable Care Act passed, you guys are saying that the people that we were serving as medically indigent, I always just thought of that as shorthand as people who had to wait in emergency rooms, who went to emergency rooms once things got bad enough. But of course, counties also run clinics, and you're saying those clinics, there's fewer of them. We actually closed clinics, and some of those workers presumably went to work for some of the health plans around the state.
Not even just in clinics that we owned and operated, but even in the clinics that we contracted with.
Mm-hmm.
So whereas they had long-standing contracts with clinics to provide services in some areas, those contracts may or may not exist, and in several areas they probably do not exist anymore.
So we'd have to, revive the contracting process, figure out, like she said, the capacity and workforce issues. Yeah, that would be a big deal.
And then counties have also been doing a lot of work, at least here in California, I assume other places, in trying to make sure that people that are coming out of prison and people that are in jails have been getting health care, and we've been trying to make sure that people are signed up for the appropriate programs for them. Would there be effects, we think, on public safety, or just on the amount of money that it costs jails? What kind of effects would we see there?
We're really worried about that interaction. 2011 realignment was based on the premise of the Affordable Care Act being available, because 2011 realignment really married the health and human services side of the world, which included healthcare and mental or behavioral health care, with the criminal justice side of the world. And the whole idea of 2011 is if you can get those folks, when they're coming out of jail, into a substance use disorder or behavioral health or other supportive program, you can reduce the recidivism rate. And that's why 2011 realignment is kind of that you've got public safety and health and human services married. If the ACA goes away, the expansion, the people who now can access mental health care and substance use disorder services, which are the single childless adults, which are typically what you find in county jails, won't be able to access those services. So we would have significant concerns about how public safety and health and human services have been working together really well under 2011 realignment to bend that recidivism curve. If we lose the substance use disorder treatment system, which California is really in the process of erecting, it's taken a couple of years, we've kind of had to build from scratch, to lose the progress there I think would be significant for public safety.
Well, and I know that the mentally ill in jail has been a big push nationwide. It's been one of NACO's big pushes over the last couple of years now, not just in California. Mm-hmm. Do any of the three of you, and I think, Tom, this might be a question for you, and there's a question we got from the audience, is there any chance that states have standing to take some sort of legal action, maybe against the federal government, to slow these changes down or to stop some of the changes?
I think it's now in the hands of the Congress and the administration. I'm not aware of any legal action states could take, but I'm not an attorney, much less a healthcare attorney. But the Affordable Care Act was, obviously a federal law enacted, and Congress has the ability to amend, repeal, replace any federal law on the books, and that's what they're doing now.
And then another question we've gotten also, What would happen to the 1115 waiver? This is getting a little bit deeper into jargon. So maybe if you could spend, Farah, if you could spend 30 seconds talking about what the 1115 waiver is, and then talk about what might happen to it if the Affordable Care Act is repealed or parts of it are repealed.
Sure. The state of California, in conjunction with our public hospital system, every 5 years negotiates a waiver with the federal government saying we're going to provide care in these certain ways. We have ideas on how to improve care. We have ideas on where you can maybe apply some more federal funding to help, increase health outcomes. And so this waiver is the Section 1115 Medicaid waiver is an every 5 year sort of negotiation. We just completed one in 2015 that is based on the premise, again, that those single childless adults will be covered under Medi-Cal. There are several innovative programs in the current waiver, like whole person care, which seeks to coordinate county systems to help the high utilizers, the group of people that maybe end up in the ER all the time or end up in jail all the time, to try to unsilo some of those county systems to serve them better. That's premised on the fact that we can draw down some federal funding through the waiver for serving those people. I think the policy work of the waiver still stands. It's a legal document negotiated between the state and the federal government. So all of those policies and programs that we have in our waiver will, of course, still stand. But it is the fiscal underpinnings that give us a little bit of worry about how much you could actually draw down for maybe serving someone in whole person care. We would be very concerned about any threat to the waiver programs. That would be a big concern of ours.
Well, if the waiver programs were negotiated under the assumption that the single childless adults would be covered, and then half of them aren't, say, then wouldn't the waiver, the programs that were negotiated in it, wouldn't that make them unworkable?
It could. It could. We would do everything we could to salvage something in the event of that worst case scenario. The other thing I would add is that those people who lose coverage are going to end up at our public hospitals and clinics as uninsured, and it will be uncompensated care costs. So not only will our public hospitals and health systems potentially take a hit on some of the innovative waiver programs that help reduce the cost of care while improving it, but they could also see significant increases in uncompensated care. That would be a real double whammy for our public health system.
And when you say uncompensated, it's uncompensated because of the AB 85 shift?
No, uncompensated because a person who walks into the ER, you must serve them.
Sure.
They can't pay you.
But weren't counties getting money to do all that before through realignment?
With hospitals and public hospitals and uncompensated care, depending on the county, there may have been some realignment funding for that, but the rates of uncompensated care were so large that our public hospitals and health systems really operate on a razor-thin margin and require a lot of different state and federal and local funding streams. So uncompensated care broadly is just the cost of care you provide that people can't pay for.
And so what about the ballot measure that just passed, right? California just passed an extension, you could say an extension of the tax increases from a few years ago, and some of that money is, depending on how it comes in or how much there is in any given year, some of the money is to go to pay for Medi-Cal. So will that help?
I think it's better than not having anything. We had several propositions that tobacco taxes, which also includes e-cigarettes and vaping, so it's kind of a newer revenue source. Last year's MCO tax some of that goes to Medi-Cal.
And the MCO tax is the tax that is specifically designed to draw down federal money.
Draw down some federal money, but have the managed care organization, I'm sorry, I used the acronym MCO, contribute to the healthcare system in which they operate. And so there are some newer revenue streams for Medi-Cal, but each of these things I've mentioned, as well as a few others, is $1 or $1.5 million. It's not a lot.
Did you say 1.5 million?
Million, yeah. Not a lot. The tobacco taxes is maybe, it's very, very low. The MCO tax is actually maybe up to 300 million, but that remains to be seen. So there are dribs and drabs coming in, but nothing that could, help the state with a 16 to $20 billion shortfall.
What are some of the other effects we haven't talked about? We've talked about some of the public safety effects. We've talked about the effects of not having the same clinic infrastructure that we had before, as well as the funding shortfalls. We even talked about the expectations of patients, now that some of them have become patients of kind of standard health care instead of emergency health care. What have we missed?
We haven't talked about public health effects. I think one of the things that folks should keep in mind is that the Affordable Care Act created the Prevention and Public Health Fund, and that is part of the CDC's budget, so the Centers for Disease Control, and it's roughly about 12 to 13% of their budget. It also allowed some money to flow down locally to various entities. So some counties and cities and community-based organizations within California received, and I want to say it's about $19 million that we received from the state if you kind of calculate all of the entities that got it. But the Prevention and Public Health Fund is the first fund that was really dedicated at a national level to public health. And it's different than healthcare, right? It's more focused on the prevention side. And that's something that should not be lost on folks, that the value of prevention is huge and it has a significant impact on our communities. I think the other thing to note too is that preventative services is included as one of the 10 essential health benefits of the Affordable Care Act. So should, certain things, the essential benefits be revisited under a repeal of the Affordable Care Act, whether health plans would continue to provide those preventative services we would have to see what the impact of that would be. And even though not directly in the Affordable Care Act, I think there's conversations about immunizations and things like that happening at the federal level, and the science, folks having a disregard for the science of vaccinations and so forth. And so part of the federal funding that we get for certain parts of public health, including things like vaccinations, may be at risk as well. So there's huge impacts on the public health side, not just to the funding, but also to some of the infrastructure. We get a significant amount of our funding directly from the CDC. So if their budget continues to get challenged, there could be public health implications.
I think that the upstream effects in both public health prevention and behavioral health, the Affordable Care Act, some of the essential health benefits are behavioral health benefits in parity with the healthcare benefits. And if we can't treat people before they're in crisis, whether it's a behavioral health crisis or a health crisis, or there's a breakout of measles in your community, it costs us all a lot more money. And the Affordable Care Act really made every system focus on prevention. So losing that focus on prevention could have significant downstream effects too.
Well, so what's to be done? Obviously, we've sent a CSAC along with CHIAC and our other several of our other county partners have sent a letter to Congress. So we're advocating, and Tom Joseph and the other folks at Waterman and Associates are advocating on our behalf. And if I understand right, our main message is that any repeal has to be paired with an immediate replacement that takes care of the biggest issues. So that's whatever's going to happen at the federal level is going to happen. The state's going to have to deal with it in some of the ways that we've discussed here. What can counties do either to prepare themselves or once it happened, what kind of options will they have? Because counties don't have a lot of revenue authority. Most of the revenue authority counties do have is limited, either in the amount of money it raises or who it can be charged on. So what might happen? What might counties think about planning for?
That's a tough question. There's so many uncertainties, and I know we keep saying that word today, but I would advise counties again to brush up on your Section 17,000 obligation. Your county councils are very well versed in that obligation. Brush up on what your county used to provide and what they might need to provide in the absence of the Affordable Care Act. I think we're trying to make sure that our counties have as much information as possible. In working again with Tom and DC and other places, there will be opportunities, I think, for counties to participate in our lobbying efforts, chiming in at the federal level, testifying at the federal level, and then working again with our state partners on what it might look like for California. We would really have to not only have our focus on the federal government, but as you've mentioned several times, Jeff, in your questions, we also really have to have our focus on what the state government does as well.
And Tom, can I ask you, at the federal level, is CSAC's advocating and our partners are advocating, you're doing it for us. Who are the senators? Obviously we have two senators from California, but are there other senators in particular that we should be focusing our efforts on? Ones that are focused on the replacement aspect of repeal and replace?
Well, there are, and you know, we will be working closely with NACO to work with these other states. A number of these states, at least the Republicans so far that have expressed concerns, unfortunately aren't from county-administered states, but a couple of them are indeed from county-administered states, namely Senator Rob Portman from Ohio and Senator Ron Johnson from Wisconsin will be two key county-administered states.
And when you say, Tom, let me clarify. When you say county-administered state, you mean states where the county administers the Medicaid program?
Thank you. Yes.
Okay.
Yeah. Nationwide, depending on the program, counties rather than the states, of 10 to 15, depending on the program, 10 or 15 states. It's the county government that administers health and human services programs on behalf of the state. So those are key states to work with, and CSAC just today, in cooperation with Cook County, Illinois, and we'll be reaching out also to the CSAC equivalent in New York, introduced a resolution for consideration at the NACO conference at the end of February that essentially says if there is a repeal effort, a replacement bill must go hand in hand with that in order for counties to be able to plan for a phase out of the Affordable Care Act and a phase in of whatever the new program would be. And that, as we've noted, the replacement is still very much an outstanding issue.
I love the quote, I think it was from Senator Schumer in New York, that he said, you know, you don't tear down a bridge and then build a new one. You know, use the old bridge until you've got the new one ready to go. So we're hoping that that is gaining traction in Congress.
Sure. Well, if any of you have parting thoughts or things that you were hoping to say that you haven't had a chance to, I think now's the time. We just have a couple of minutes left. Any other parting thoughts?
Well, I would say first is that the repeal of the Affordable Care Act or changes to the underlying fiscal underpinnings of the Affordable Care Act have severe impacts for counties, the potential for severe impacts across most of the county health and human services systems, as well as probation and the sheriff department. So I think counties need to pay close attention. We're sorry we don't have anything really solid to give you about what's going on, but pay close attention, be prepared, and also I think understanding the impacts in your own county, how many people are maybe served in your county. Some counties have a larger population of people who are on Medi-Cal than others, and the impacts for those counties would be even more significant. So getting a sense of how the ACA might impact your specific county, I think would be a really good thing to do. But I just want to reiterate that the impacts will be felt across many county systems.
Yeah, I would just echo that thought that, you know, the repeal of the ACA impacts all counties ultimately. And so we all have to work collectively to figure out the best approaches. I think talking to your statewide organizations who are doing lobbying on behalf of your efforts and so forth, and just making sure that the messaging is clear, and knowing that, you know, a repeal of the ACA, potential changes in the enhanced matches and things like that has impact statewide. It's not county specific. It's across the board. So knowing that folks are here, we're working on it and doing our best to make sure that California is left in a great place. But obviously we'll continue to provide updates through your respective organizations to make sure that we provide all the information that we can.
And this is Tom. You know, the Affordable Care Act is very much front and center out here for us representing CSAC. It is the all-consuming issue for me. We sort of know the conversation around repeal, and we await to be able to have a conversation with Republican leadership on whatever their replacement bill looks like, but we aren't able to have that conversation until we see some of the details of that plan.
Well, we certainly appreciate the work that you're doing out in DC. Tom, I appreciate the work that Farah and Michelle that you guys are doing here in Sacramento. I want to thank all three of you for being here. I want to thank everybody that tuned into the presentation for tuning in. Until next time, we will be back next month with another presentation like this one on a different subject. Until then, thank you all.